like to introduce our next speaker, my dear friend, Dr. Reggie Hamdy, who is here from Montreal, Canada. Reggie is a professor at McGill University, the chief emeritus at the Shriners Hospital in Montreal, and the past director of pediatric orthopedics at McGill. He's also the director of the Limb Lengthening Clinic, the Arthrogryposis Clinic, and the Osteogenesis Imperfecta Clinic at the Shriners in Montreal, and the past president of LLRS North America, the Limb Lengthening Reconstruction Society of North America. So Reggie's going to talk about limb optimization for severe congenital limb differences. Thank you, Reggie.
Thank you. So I am Reggie Hamdy. Thank you for the introduction, Sanjeev. And I have no disclosure. So first, I would like to thank Sanjeev for kindly inviting me. I really appreciate it. I'm sure it will be a great meeting. Just a greeting from Montreal. This is one of our favorite historical monuments in Montreal. And if you come and you don't like to visit this, we have lots of nicest restaurants there, just in case. So the objectives of this talk, if you have cases like this presenting to you, like a case like this, very severe fibular hemimyelia, or another case like this of a PFSD and severe hemimyelia, what are the options for optimizing the limb differences and how to decide which option to choose? So these are essentially the two objectives of my talk. First thing, what are the options that we have available for optimization of the limb difference? Essentially, it falls into two big subgroups, either surgical reconstruction or prosthetic reconstruction. The surgical reconstruction, there is no amputation, no prosthesis. Multiple surgery can be performed in the hip, knee, ankle, gross modulation with diseases, multiple lengthening. So all involve surgical reconstruction. Prosthetic reconstruction can fall under really four subgroups: amputation and then prosthetic application, surgery and prosthesis, surgery and amputation and prosthesis, or simply we have some patients or some conditions where only prosthetic treatment is an option. And we'll go quickly through an example of each one, but this slide summarizes essentially that we have numerous options for the treatment. The first option, well known to all of us, is surgical reconstruction with a multiple lengthening. So that's the case of severe fibular hemimyelia. And I think everyone agrees at that stage that yes, multiple lengthening and surgical reconstruction is probably the option number one. The second option, it is optimization by amputation and prosthetic fitting. So we have here an example on the left, the severe fibular hemimyelia. And as we are going to see in the next few slides, after discussion with the family, it was decided to proceed with an amputation and prosthetic fitting, which again is an excellent option in many indications. The third one, which is optimization using surgical reconstruction and prosthetic application with no amputation. And we have here some parents who simply refuse an amputation. Therefore, in a case like this, we have a severe PFSD, and here it was reconstructed using, you can say, super hip, and then the unnecessary rotational plastic. That's the end result, where the ankle becomes the knee, and then we have ankle preservation was done, and this is a Van-Ness prosthesis. The fourth type, or the fourth option that we have in limb reconstruction is really a combination of a bit of everything. So that's the case of severe tibial hemimyelia with the bifurcation of the distal femur. Really, one of the most reasonable option would be simply a knee disarticulation, epiphysiodesis of both stumps at the distal femur and the prosthetic reconstruction, and as you can see here. That's another example of the fourth option where all the possibilities are applied. You have a case of tibial hemimyelia, type 2, that is healed with tibial stump, and that was surgically reconstructed by centralization of the fibula under the tibial stump. That's the result, and that's the final result when you have the prosthetic thickening. And finally, we have the fifth option, which also happens is that the parents refuse any type of amputation, they refuse surgical reconstruction. In that case, the only option that we have is prosthetic fitting. Here, it's an ischial weight-bearing prosthesis. That's another case, very severe PFFD, almost the whole femur is missing, and the parents don't want anything except conservative treatment. So we have the foot and ankle is capped, and we have these prostheses. Sometimes you use an extension prosthesis. So we have many options. The next question of the next objective, how to decide which option we use for optimization. And I would show this, which is my first slide, and that's the theme really of most of this webinar. It's a team approach that we will decide. So this, we have a limb lengthening and deformity correction clinic that includes all these people, and it is in this clinic that all these options should be discussed ultimately to reach a shared decision-making with the family. And this is the key thing now. We cannot use anymore a sort of paternalistic attitude, simply telling the patient, look, that's what you're going to happen. That's history now. And using this multidisciplinary team and the family input and the patient, whenever possible, will reach a shared decision making. Besides the clinic, also there are lots of supportive material that can be used to help the patient and the family reach a reasonable plan of treatment, and that includes the brochure, the multiple dolls to show the external fixators. We always, the families who have children affected with this and say we plan an amputation, then they can see and meet other families and other children who had the same treatment. I'll just give you an example quickly of all these things. We have a case of severe fibular hemimyelia and two options, number one, preservation, and number two, amputation and prosthetic filling. How do we approach this thing? This slide, it's a very simple one, but it's very important. In all these complex pathology, we are going to follow the patient until skeletal maturity. If we see the child at birth, then it's a very long journey. It will take many years until skeletal maturity. And we have to come with a lifelong treatment plan that will span all these years so that the parents and the family will know what to expect. From us, we have the first visit, and that's the most important visit. Obviously, the parents are very stressed. They don't know what is going to happen. So we should take our time. We should address their concern with anxiety. We have to explain what it is, all the problems that can happen, and then the lifelong treatment plan. You will see this sentence is repeated several times because I think if there is one message for all these things, we have to give them a detailed plan of what is going to happen. So before deciding on the treatment, we have to explain to them all the problems. Here, for example, this fibular hemimyelia, we go from a hip dysplasia, from the LLD, how much will be at skeletal maturity, the knee instability, ankle deformities, foot, and the malalignment. So all these have to be addressed. Two more things have to be discussed because that's very common. And the parents always want to know how much can be lengthened. The answer now is with repeated multiple lengthening, the sky is the limit. However, we should respect that for each single lengthening, 20% remains the magic number. The second thing also is that very often we cannot give a definitely plan of treatment. We cannot make even a careful or a detailed diagnosis. We have to wait a few years until something like this, for example, an aesthetic center appears. And after having done this, we meet with the family. Very often we meet with them more than once. And there is no rush to give a plan of treatment in the first visit. Always bring them second time, the third time. After having examined, after going with them through all the problems, we have these 5 options that I mentioned before. So the first option, which is preservation of the foot and ankle, after talking to them, we have to give them this. An example, in that specific case, the patient will need 3 lengthening plus minus contralateral epiphysiodesis. So that makes 7 surgery. He might need a super ankle, he might need a super knee, he might need the hemiepiphysiodesis for surgery. So on the average, a severe fibular fibromyalgia that we preserve the foot and ankle, on the average, we need 12 surgeries in spanning all the year to skeletal maturity. And the same thing if we apply PFFD or fibromyalgia, very, very important to give them this picture. If we go for an amputation, then it will be mostly 1 or 2 surgery. So again, the success of this planned treatment depends on this multidisciplinary clinic, the teamwork, and the shared decision. The take-home message: approach to this pathology has to be in a multidisciplinary clinic, all options to be discussed, lifelong plan absolutely necessary, and this shared decision. I put these slides again here, simply saying that it's a very long journey. Thank you.